a great pleasure to welcome everyone today to the Pearl Lectureship. I think starting this prior to Dr. Pearl sort of leaving Peoria, I think a lot of us are here, and there's no one in the Children's Hospital and OSF who doesn't know Dr. Pearl. So, he recruited me here in 2012. We were, partners and friends. We shared a vision for pediatric surgery. I think he brought me along in surgeon-in-chief duties very early. I think between taking care of patients together, talking about our families, talking about desires to both for the practice and how to best take care of kids, we were always lockstep. I think it was a great loss of ours when, as we, to lose him from Peoria, lose him from the community and move to Cleveland to be by family, which we understood, and to, retire and pass on. I think with technology that we leveraged with COVID and Teams meetings, Zoom meetings, and all the virtual, we have the benefit of that now with our pediatric surgery conferences and M&M to have his presence with us, as we have these meetings. To welcome him back this year was outstanding. And Emily, thank you for bringing him out from Cleveland. When we talked about who we were going to invite to be the Pearl Lecturer in 2025, it was actually early on, Ed, that we thought Dr. Barksdale would be a great person to come. Dr. Pearl's in Cleveland. Dr. Barksdale, after college at Yale, did medical school at Harvard and was at Mass General for residency and fellowship at Cincinnati. And working as a pediatric surgeon in Pittsburgh, he then moved to Cleveland and had a distinguished career in Cleveland. Only recently, now going to Chicago and the Health Alliance with Advocate and University of Chicago. And so those overlapping ties and knowing each other over their years as pediatric surgeons and colleagues, our recent discussion of colleagues at Pediatric Surgery is a Small World. We extended the invitation to Dr. Barksdale. You cannot not have a good conversation when you talk to Dr. Barksdale. Our first, email exchange turned into a let's chat for an hour, and we filled the hour of conversation and getting to know each other. And I don't know if he remembers, but at a surgeon-in-chief's meeting, we sat at a table together with Jeff Upperman in Nashville and him, and we talked about healthcare and problems and solutions and other things that we could do. So he has been a factor even in my kind of leadership career as surgeon-in-chief. We're very excited for his talk today, Beyond the Walls, the Unseen Power of Simulation and Social Innovation. Dr. Ed Barksdale, the 2025 Pearl Lecturer.
And two, is my microphone going to work? Peoria, good afternoon. It is absolutely wonderful to join you here in Peoria. And let me just stop fiddling with my mic. I have never been here before. And so it makes it so very special to join you. I left my clicker. So I bring you greetings from up north, and up north here means Chicago, where I serve as professor of surgery and pediatrics at the University of Chicago, and where I am also the chief surgical officer at the Chicagoland Children's Health Alliance, and Advocate is a part of that. This is your city, huh? Absolutely beautiful. I didn't quite get this view yesterday, but I got an even better view from a bluff overlooking the Illinois River at the Peoria Country Club. Such a beautiful evening and a beautiful time with your colleagues. What a wonderful institution. OSF, Children's Hospital of Illinois. I am delighted to be here. That's not me. I guess you didn't know that. But I show this picture because this is really the only thing that I ever knew about Peoria. I hope this doesn't offend anyone because there are probably some girls who want it or women. But when I was a boy, I always wanted to drive a backhoe or a front loader. And I knew they were made by Caterpillar. And and that Caterpillar, I guess, used to be here in Peoria, still is here, but I was absolutely delighted. And for me, Peoria has always been at the center of what's called the heartland of America. And in many ways, when I kind of knew about it and looked at things on the map, in addition to being at the center of the heartland, it's also a place that is at the confluence of railways and rivers and manufacturing and imagination. What a very special place. And I'm delighted to be here to spend a little bit of time with you. What I've learned is that Peoria stands as the quiet pulse of a nation, a place where the ordinary has always carried extraordinary weight. Here in the heartland, resilience, which I will talk about today, is not just a slogan, but a way of life. And it's where hard work meets humility, and innovation is not born in skyscrapers or even in centers like this, but innovation is born out of a sense of shared purpose. This city reminds me of the center of America, and that center is not found by any level of geography or any map, but it lives in the people. And these are the people who till the soil, heal the wounds, and believe still in the purpose and promise of community. As a kid who grew up in the South, this felt very resonant to me when I landed yesterday. And even though we don't have cornfields where I live, just flying over the nicely manicured cornfields was pretty special for me. So the other thing I knew from a kid is that it's got to play in Peoria, otherwise it's not necessarily valid. 1988, Toronto, I first met someone who was about as prototypical of a New Yorker as you could imagine. A little bit brusque, brash, loud. As the genteel Southerner that I tried to be, I looked up to him, but I was a little bit afraid of him, and you guys know who this is. This is Dr. Pearl. And this is something that he wrote, and I recognize that I'm in a religious facility. I recognize that my mother is looking from heaven to me and telling me to be like my father. So I won't give the exact quote, but Rick, if I can call you Rick, Rick said, when I left Vietnam, I literally thought to myself, I'm not going to take anything off of anybody the rest of my life. And Rick, I'm sorry, they're calling me from Jamaica of all places. I'll turn that off. And so Rick, that's true, right? And that's the way you have been. But all of us have what my grandmother would call, or many of us, an Ecclesiastes moment. And an Ecclesiastes moment is a time in our life when we are tapped on our shoulder and offered a chance to do something very special. And what a tragedy it is if that moment finds us unprepared. And I think it was Sister Judith Ann who tapped you and helped you realize that there was a potential purpose that existed here in Peoria that both you shared in your vision. And I think in many ways, this has been your finest hour. Who would have ever believed that this Boy Scout would ultimately be this man? But he has that purity of a Boy Scout, the good looks of a young man who played football and then became an actor, and then dropped out of college to defend our country in Vietnam, and then again in Desert Storm, I believe. And so thank you for your service for me. Thank you for your service for pediatric surgery, and obviously thank you for your service here. But this is kind of the Rick I know and have been very proud of. What a good looking guy you were, huh? So, as I mentioned with this Ecclesiastes moment, there are events that occur in our life that may be traumatic for us, but they help provide us with a new vision, a vision of how we think the world should be and how we think we should be in that world. And for Dr. Pearl, it was this idea that medical simulation might mimic what was happening in the world of aviation. And that in order to limit the stress of doing things over and over again, preparing when we were not in the midst of the stress through rehearsal would be very important. And so we are, the Jump Center. And this is something that Dr. Pearl has co-created with others, and what a remarkable place. I just spent time this morning going through the floors. I felt like I was walking through a museum. And the first time you walk through a museum, you realize you got to come back and spend more time in one room, and maybe that you have to make separate trips. And I think the vision of this place is remarkable, not just in the way that it transforms the way we do simulation and education, but how it moves from education, simulation to innovation in a way that is meaningful for us. You guys know all the stuff. I won't go through this. And I'm sure, John, there are other patents that have emerged from here. But what most attracted me this morning was the things that are being done for the future to train and inspire people to be nurses, technicians, physicians, and other healthcare workers, or just learn how to develop and embrace their humanity. Rick, this is somewhat for you, the actor in you. Maybe you would have been in Hamilton or Rent, but when I think of innovation centers, I think much of what I have here. This is the stage of a rehearsal for a play. In fact, it's Hamilton. And as you recognize that a lot has to be done behind the scenes, a lot of preparation or rehearsal that needs to be done ahead of time. And in so many ways, in my opinion, that simulation and what's being done here is the stage where medicine rehearses for humanity, and where what you do here is teaching all of us, not only just to save lives, but to think about how we can save whole lifetimes. And so that's the essence of my talk. For anyone who's going to leave, this is the message, but I want to walk through some of the things that we've done. So I'm here for 3 reasons, and I have educational objectives. The first is to honor Dr. Pearl. The second is to pay homage to Dr. Pearl and all those who have collaborated to build this remarkable center here in Peoria. And then the final, which may be a little more controversial, is that I would like to challenge, if not inspire you, to think of simulation and technological innovation through a lens of social innovation. And so my talk is listed here. I want you to think beyond the walls of this facility, geographically or metaphysically, and so you can look into the world to determine how you can take what you do here to have impact, because all of us, in whatever way, want to have impact. Have really ambitious objectives. You can see these here, but in effect, what I want to do is I want to go through the traditional applications of simulation. I'd like us to analyze them. I'd like us to apply a concept that I will introduce to you based on a program that we developed in Cleveland over the last decade. And then hopefully you can design something that is important. You guys know so much about simulation, so I really don't have to tell you about this. I'll kind of rapidly go through through here. But as you know, to many of us, it seems like simulation has its earliest roots in aviation. But in fact, back to the ancients, back to the Babylonians, they had simulation. They built clay models to look at the liver, and in the Sanskrit medical transcripts, which you see here, there's a description of how simulation might be used in the care of patients. But I'd like to call your attention to this overly crowded graph, and what you will see is that it seems like there was a lot of stuff done in what I would think of as antiquity, but there was a dead period, and much of that dead period extended up until the 1960s or so. This is how I trained in in surgery and in pediatric surgery, and Dr. Pearl trained in that same way. The Halstead model, which was an apprenticeship model. And as we say, you see one, you do one, you teach one, and in no impolite way, you have to mess up one before you can teach one. And I think all of us would acknowledge that this is no way to learn. None of us would want someone to have a medical error on our loved one. But in many ways, we had a very bold view about what surgical error and what training was. And so I call this period from the late 1800s to the 1990s, that 100-year period, as being the dark ages of understanding simulation and training. And then we realized, because there were parallel things going on in the flight industry, planes were crashing, there was chaos in the cockpit, there was chaos in the control towers, that we needed to think about rehearsing what happened in stressful situations, creating models so that we could have the catastrophe on the ground and not in the air. And then the rest of the stuff, things really exploded. I graduated medical school in 1984. There was really not much use of simulation then, but over the last 40 years during that period of time, how things have trained, and I wish I'd had access to many of these things. So those of you who work here, you understand that these are essentially the 7 components, and they not only relate to surgeons, but they relate to teams, and they relate to systems, and they relate to education. And you here at the Jump Center have taken this to a much, much greater and sophisticated level. But in essence, a little bit confusing slide as a surgeon with a little bit of ADD, I think, in terms of pictures and images. And you can see that all the different components shown on the last slide all integrate around these components of simulation. And when I look at this, I can't help but ask myself, what's missing from this? As you reflect on this diagram, what's missing? For me, in classic simulation, what's missing is the human component. And so as we think about simulation, education, and innovation, we have to keep at the center of who we are and what we do, what's best for patients. And you can take a picture of that, what's best for patients. And also, we also have to think what's best for providers, because we're not separated. There are a lot of limitations to simulation. And, I've been in environments where we've been caught up with the simulation process. And now the cool thing is the virtual reality and augmented reality, which I think is great. But sometimes we get too caught up in the technical focus, and that we think that what we're doing in simulation is making us safe, but it's really not always making us safe. It's an artificial situation that's very predictable. And when I look here, such an incredible facility, lots of resources go here to make this phenomenal. Not every community or every hospital system can afford this level of physical talent and human talent, which is phenomenal. And the other things that you see, I think are important, and particularly for me, and I've decided not to talk too much about my background in this talk so I could get through my slides, is to understand that some simulation centers neglect the gaps in the social determinants of health. And I thought that when I arrived here today, that would be your center. And I realized that I was very wrong. So what's the next steps in simulation? You can read the slide, but for me, the big components here is that we need to think about how we think about community and how we think about how communities, which are fragile because they are either rural or urban or affluent, how we can take health care into the community. And what I'll talk to you about in the work that we've done is this concept of human-centered design. How do we put humans at the center of technologic and innovative developments? And there are three major components. Inspiration, that is, we can observe and learn and be humble. And I didn't bring up my moleskin, which I keep with me, that I take notes to learn from every endeavor or interaction, whether I'm in the inner city or whether I am at a dinner. And then how do we design? How do we ideate? How do we create an image of what a prototype would look like that we can test and then revise? And then how can we implement and then revise again? These are the core principles. We'll go through this a little bit more. And so I think that those are the opportunities for every center like this to begin to think about how can we dynamically infuse the human component into the design component, because I don't feel that simulation and innovation is all about doing the operation better, faster, or slicker, or creating a better device. We focus a lot on the technology and we focus a lot on health care because we think that we can improve life. The classic outcomes for health outcomes that we deal with are premature death, disability, and disease. But in fact, most of the health outcomes, 70%, are determined by what's called the social determinants of health, where we live, where we work, and where we play. For me, this was a fairly devastating publication that came out in JAMA this summer. And if you can read the bottom line without difficulty, it says that for the first time in our lifetime, that Gen Zs are expected to have a shorter life expectancy. And this is due to increase in chronic diseases, increase in what's called the deaths of despair, and a number of things, gun violence as well, which may be a part of the deaths of despair. So the second message that I hope that you will take away from this is to remember that healthcare occurs in the hospital and health occurs in the community. And how can we improve those health outcomes? How would each of you define medical excellence? Think about it. Is it safety? Is it innovation? Is it the quality of care? Or is it those outcomes we talked about, length of life and things of that nature? Well, if we look at length of life, I've touched on that. This is a report that was first promulgated around 2010, and then during the 2016 election, got a lot of press. And this is the decline in American life expectancy. 1 in 25 Americans will die before the age of 40. And why is this happening? You can see the slides here. And these researchers, husband and wife team, Ann Case and Angus Deaton from Princeton, wrote in PNAS this now classic paper that looked at the differential morbidity and mortality of white males in particular who live in the heartland and in the center of the country, who were dying earlier. And they coined the term deaths of despair. And they felt that this was a threat to our economy. And why were people dying? Well, they were dying primarily because of suicide, homicide, alcoholism, and overdose. That's a big deal. And now, since that time, this has moved from middle-aged white populations to Black and brown populations, in which the incidences of suicide and substance abuse and homicide have grown tremendously since the pandemic. So this is not a regional problem. This is not an ethnic problem. This is not an age problem. This is an American problem. And so I challenge us as we think about innovation and simulation. Are there ways that we can create models to help us as providers become more empathic to those that we serve? And so someone may be sitting there and saying that that's not what's happening in Peoria. But one of the nice things about getting an invitation about 2.5 months before you come, I started watching online the Peoria News. I started reading some of the articles in the Peoria newspaper. I wanted to understand a community that I'd never been to before so that I could think about whether I could provide value in whatever 45, 50 minutes of fame that I have or infamy that I have here. And so, do you guys recognize this guy? Yeah. He is prominent in the media outlets. And so I read a number of things. This is your coroner, your coroner. I hope I never see him, or I hope I'm never viewed by him. I'm fine with being seen by him, but I just want to be viewed by him. Again, you see the numbers. Homicide, and as he says, if gun violence or violence doesn't get them, then suicide will for many of the young people here. So this is pandemic, not just epidemic, but the violence, self-violence, and other violences is something that we need to address. I also read the 295-page Community Health Needs Assessment for 2025. I didn't look at any of the other years, but I found this interesting because although Peoria looks nothing like Cleveland, Ohio, the themes are the same for the health drivers between here and Cleveland. So economic and racial inequities drive the health of Peoria, but the principal drivers I've put in red of health, behavioral health. That's the way it is around the country. We are also having a pandemic of depression and stress. Chronic disease prevalence, that is a little bit high here, diabetes and heart disease, which has some to do with physical activity. And something that I found incredibly interesting in the midst of an area for me that I flew over with tons of what I think were cornfields or soybean fields, that there would be food insecurity. But food insecurity is high in this community. Are most of you aware of that? Yeah, it's surprising in such a land or region of plenty that there would be food insecurity. And then the environmental hardship, which essentially means housing inadequacy that exists. And so these are the major issues driving care. The systemic barriers to healthcare access mostly has to do with mental health access. So I'd like to ask you, and I'd like to ask the leaders, are we leveraging the advanced simulation and innovation that's done here to improve health in Peoria and the 3 adjacent counties? So I made this slide before I took a tour, and I got a resounding yes, yes. And Rick said, Ed, what are you talking about? Let me tell you what we're doing. And so I must say I'm incredibly impressed with how the Sim Center and the innovation here is moving from healthcare to health in a way that makes life meaningful for people. I hope that the Sim Center is having partnership for a healthy community. I read their report. Lots of good things being done by non-profits, not-for-profits, that hopefully will improve the life of the community. So I'd like to divert a little bit to talk about something that has become a reluctant passion for me. So in 1994, I started my first academic job at the University of Pittsburgh. I had a laboratory. I made cancer vaccines for pediatric cancer. I worked on patents. I saw myself as a scientist. I'd previously worked at a place called Biogen, a biotech company in Cambridge. And my goal when I got to Cleveland, to Pittsburgh, was to be a good technical surgeon, develop a program. We developed a very large program, a kind of a world program for a clinical problem. And I wanted to be a scientist. And I wanted to stay as far away from trauma as I could. Why? So I was born and raised in a place called Lynchburg, Virginia in the mid-1960s in a working class family, 2 parents, my neighborhood. All of my neighbors looked like me. All the houses had 2 parents. All my friends in my neighborhood, but not my school, looked like me. But by the time I graduated Harvard Medical School in 1984, at the age of 25, 7 of my 9 closest friends were dead or in prison. And that was absolutely unbelievable. And so I think for me, the reason I don't like trauma or violence is I just don't want to think about it. But the reason why I think about it all the time now is because I have survivor's guilt. And so sometimes you realize that you must have been spared for a special reason. You guys have to be living under a rock if you don't know that there's a gun violence problem. When I looked at the numbers in Peoria, there is somewhat of a problem, but not to the magnitude of Chicago or Cleveland. But it will be getting here at some point unless we take active means at looking at the solutions. We're a country of guns, and that's just the way it is. And so I think we're not going to be able to take away guns or limit anyone's gun. That's un-American. But we can help people do things for gun safety. I do a lot of work with Moms Demand Action. That's about safe gun storage and education regarding guns. I was one of their awardees this year, but I feel very strongly about responsible gun ownership, not taking away anyone's gun. Have you guys seen this graph before from the New England Journal? Can I see a show of hands? How many have seen this? So less than half the crowd. I think if you look at that, and this came out 3 years ago, Crossing the Lines, the important thing to notice in this graph is that gun violence is now the leading cause of death for children. Gun violence across the entire country. That's staggering. And so many of us look at this graph and say, oh my goodness, this is awful. Others of us look at this graph and say, oh my goodness, here is opportunity. Because when I first started as a young pup in pediatric surgery, a ton of kids were driving in motor vehicle crashes. And then there was a massive campaign to wear your seatbelt, to put your child into a car seat. And lo and behold, look what happened over that 20 years. So it tells us that public health methods can make a difference. And what I would hope to inspire or challenge you is to think creatively about how we can educate the public that it's okay to have a gun, but can you store it safely? Can you consider separating the ammunition from the weapon? Can you put it away from children? Can you be aware that if someone has depression in your home, that may be problematic? So I hate guns, I hate violence. I mean, I don't hate the fact that people have guns. My mother slept with a gun at her bedside when I was a kid, so I'm used to being around firearms, but I certainly hers was not always appropriately secured. So this was my Ecclesiastes moment. And I hope it's okay in a Catholic hospital to say Ecclesiastes. People are familiar with that. Yes, sister, thank you. I got some strange faces when I said Ecclesiastes moment doesn't necessarily have to be religious, but it just has to be that time when something happens, like with Dr. Pearl, where you become changed. So for this kid, growing up in a working class neighborhood in Lynchburg, Virginia, at the jagged edge of Jim Crow, who worked really hard to be named the chief of surgery at a major children's hospital in 2007. It was pretty special for me. And, but unfortunately, my first patient was a 14-year-old boy who looked just like my 13-year-old son, who came in on a Friday night, my first patient, first night on call. He came in dead with a gunshot wound to the thigh, and he left dead. And I looked at myself, I found a quiet space, and instead of patting myself on the back, as I had sometimes dislocated my elbow doing after big operation, I looked in the mirror and said that not only could I not save his life, but I also couldn't save his whole lifetime, which is a much bigger deal, and also less ego-driven. But this was the city I found. So, 7th highest crime rate in the country, highest child suicide rate in the United States, the highest infant mortality, highest poverty rate. And often when I give this slide, people turn their heads away and say, Ed, you're depressing me. No, it should inspire the creativity, the innovation, you to think about what you can do to address this. And so as much as I tried to tightrope my way away from these problems in the community and get back to academic medicine, all of those things just kept reeling me back into saying, Ed, there's got to be a way to make a difference. I've gone through this. These are some of the social drivers. I don't mean to depress you, but just see our median income in Cleveland is about $22,000 less than Peoria, to give you a perspective. So a friend of mine, a guy that I had met, I kind of loosely call a friend, he spoke for me when I was president of the American Pediatric Surgery Association, and I had met him when he was at Harvard Law School and I was in medical school. Brian Stevenson, who some of you may know who he is, famously says that if you're willing to get close to people who are suffering, you will find the power to change the world. And so I decided that this place that I had walked into, Cleveland, I was going to get close to the people to understand why there was so much violence in children. So it's emotional for me, actually. I'm not sure why I'm so emotional now, but I was in places where if my mother only knew, she would be shuddered. But I was there with law enforcement. I went into buildings where children and women were being trafficked. I went into shooting dens. I met with gangbangers in Cleveland. I did a number of things, and so you'll see I've gotten recognition for those work, but I wanted to understand the people. I wanted to understand, and I'm a wine drinker, the terroir, which is the climate, the soil in which the vines that these grapes of children were growing from were having impact. I not only went into dangerous places, I went into schools, I went into a variety of churches and rec centers in order to understand. And I developed with the mayor and the chief of police of Cleveland a program called Operation Focus. This is a tough love program. This was my social innovation based upon taking moleskin notes and ideating and creating in my mind a simulation of what I might do to help people by bringing people together to help those people. Operation Focus, a tough love program that we developed in Cleveland, anti-gang violence at that time, 2008 through 2012. We brought children in under the age of 17 into these settings in which we would read them the Riot Act. We tell them that if you don't turn your life around, we're going to send you to prison in Kansas where you'll be the bait for older men. You'll end up on a slab and your mom will be crying over you like the mothers who were there who had lost their children. We had the FBI, we had the U.S. Attorney's Office, and this tough love program that we did for children within our first 2 years got us down to the lowest murder rate in 50 years in Cleveland. So I was one of the 3 co-founders. And, you know, often the way we as surgeons are, we do something, patient does really well and goes home, but we don't always think about how it works long time. So we parlayed this into a $2 million grant from the government. We were named one of the premier programs in the country, one of 6 programs. Eric Holder, the then Attorney General, then Steve Dettelbach, who was U.S. Attorney there and became Director of ATF Firearms. He's a neighbor of ours in Cleveland, Rick. We were able to get this money, but when the money ran out, the violence rate went to higher than it had ever been before. And what I learned from all the notes I had taken, that there were a number of routes to violence within our community that our healthcare system and our social services were not addressing. Now, is it the responsibility of our healthcare systems to address these problems? Some of the leaders in my old institution would say, no, it's not our responsibility. But those children and those adults who are injured and uninsured become a financial burden, not just on the hospital and the community. And so what I learned from all the experiences that I had, that poverty was a major ball and chain on the lives, particularly of children in Cleveland. More than 50% of the children were born in poverty in Cleveland, highest poverty rate in the country. And within their environments, there were a number of systemic barriers that obstructed their path from where they were to where they wanted to be. And instead of what most of us do, we make the slow tread in life toward hope and opportunity. Many of these children had unsurmountable barriers of adversity that kept them from reaching their goals and sent them to despair, deaths of despair. And for the inner city, that often meant violence or other self-destructive behaviors. When I was in the schools, they talked about life, living in fear every day. And that was sobering. And for many of the children I met, particularly many of the young boys in Cleveland, I recognized that they had seen things that I could not imagine at their age, and that in many ways there were no children there. And again, I didn't see this as negative. I saw this as opportunity for us to collaborate broadly outside of the hospital system with our mayor, our public officials, and even our attorney general to develop programs. Those of you who practice in healthcare, PACU nurses, surgeons, you realize sometimes when kids come to you in the emergency room as well, they have fallen down a whole flight of stairs that put them at great risk for poor outcomes. And so we don't often know what's in the background. And others have lived in environments in which they have seen and experienced things that make it such that some of the injuries they experience, some of the environments they're in, create a cycle of violence that becomes repetitive. But as my grandmother would say, none of us is without grace and without potential. And so, again, you guys know these things about ACEs. I won't go through this, but I recognize the importance of childhood adversity as something that we have to address. And so what I want to do again at this talk is to challenge you to think about children, to think about how we can use advanced simulation, advanced techniques of innovation to get to children, whether they're on a farm, remotely, in the suburbs, or in the urban environment. And so as I mentioned to you, the IHI says that there are 3 major health outcomes: premature death, disability, and disease. But in my experience in Cleveland, and now my experience in Chicago, I believe that there is a 4th adverse outcome, and that is despair. And that I actually feel that despair is the most important condition that we need to be thinking about to address in healthcare. And it's what leads to depression. It leads to not getting enough exercise, weight gain. It leads to a ton of things that we don't appreciate. And we're increasingly understanding the impact of mental health. Well, sometimes you become wedded to your slides, but I am a big fan of the original Robert F. Kennedy. And he was someone that when I was growing up, I read a lot of his speeches and quotes, but he talks a lot about this concept of inurement. You see something so much, you become inured to it or immune to it, and it leads to a level of indifference. I can't imagine in a beautiful place like this, with such a profound spiritual and religious background that OSF has, that there's anyone in this room who would not take action to improve the condition of Peoria. I won't talk much about the structural violence, but Paul Farmer, someone who some of you may know, was a very good friend. We met when I was a resident. He was my medical student, and we spent for 2 weeks every other night in a place in Boston called Minor Surgery at the Mass General. And he told me of his life story. This is a person who changed medicine in many ways. He grew up in North Carolina, and he lived in with his 6 brothers and sisters, he lived in a school bus. But he was a remarkable person. So the year from 2014 to 2015 was a monumental year for me, not necessarily for things that are positive. This name may not mean to you much to you, but Tamir Rice was a young boy who was playing with a toy gun. He was 13 at the time of his death, and I guess he was really 12 at the time of his death, and he was shot and killed by the police. And as a result of that, I was moved to do something more than establish a program. We worked with a group of people. We developed the first of its kind interactions with youth policy in the country, which has directed a variety of police forces on how you interact differently with teenagers versus older patients. No, 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 this is not defund the police. This is to re-educate the police that children are not always small adults. And so this was a work that took 3 years to develop. But seeing his death really changed things for me in some significant ways. I had the worst week of my life in October of 2015 when these children, including this cherub, who they made a serial podcast about, were shot and killed, and my patient. And I'll always remember, I didn't bring it out. I keep it in my backpack. I have a purple heart that is the size of her heart that I had a chance to hold. And it changed how I thought about violence and victimhood, and started what I will talk about as I end my talk. So I was so moved by seeing these children, I said, okay, we're going to do something. We're going to create something. Again, the Operation Focus was a tough love program. That didn't seem like that was going to work. So what we did is we looked at all the children who were shot between the ages of 6 and 16 that came into Rainbow Babies and Children's Hospital. And we found that of the children who were shot, 197 were violence victims, not some were abuse, but most were assault. And we found that there was a 30% recidivism rate for our kids who had gunshot wounds. I can't figure out how a child gets shot once, much less twice, or the 7-year-old in that group who was shot 3 times within 2 years. But that's a problem with society that those of us who have any level of influence or power must address. And equally as bad, 30% of the children who were not shot came in with a depressive episode and and a suicide attempt. So we collaborated with our local university, Case Western Reserve University. They have a gigantic database. Now it's over 700,000 children with 300 million records since 1989. So they have records for across 35 different domains, as you can see here. They can tell you when someone got their vaccinations, or if they got it, if they were on any aid, everyone in the city across social class. And using this database, as I go through this really quickly, we wanted to look at violence in Cleveland. And we queried 275 million entries in this database and compared it with the numbers you see here of children. We used zip code matched controls of children. So we could compare like with like, who were in the public school system with our 71 gunshot wound injuries and our 358. And I'm going through this quickly for the sake of time, but essentially what we found using this database and big data evaluation We found that 96% of our children who were shot were in that database, and we compared them with controls, 20,000 controls, same ages, same neighborhoods, and we found, maybe this slide shows this, next slide shows this a little bit better. Sorry. There were only, I'll have to look here, I can't remember the number. There were only just under 3% of the children who had not been involved in the social services aspects of the community, and many of them had multiple overlaps. And to go back, so they were more likely to be premature. We found issues with their mothers needing social service involvement as children. They had housing insecurity. They had been in juvenile court. And the most significant thing that we found is that food insecurity was the #1 problem that they had. And to me, that's something that was treatable. I got in trouble with NPR because I told them that the children left home to forage for food between 4 and 8 at night, and someone was offended by that. But that's what they were doing. They were hungry, and hunger is a major driver of behavior. And so this concept that we have of treating and streeting is just not the right concept. We need to create an ecosystem of care that addresses the multiple issues that people face. And I don't think this is political at all. I think this is human. And so as we kind of begin to close, have a denouement, and I'll tell you about our program. You guys all know what this is, right? This is a broken femur that's healed. And a student asked Margaret Mead, Professor Mead, what's so significant about this? And she says that this is the first sign of civilization. And the student said, what's that mean? She said that this means that someone stayed with that person and nursed them so an animal wouldn't kill them and so they wouldn't starve. My grandmother, I don't know really why, born in 1886, fluent in German and spoke French, would always, and was the first Black social worker in my hometown in 1906, would always use this word, an accompagnateur. And what an accompagnateur is, in her words, is someone who goes along with someone. And so when I looked at the children that I had seen, that I realized we shouldn't be focusing on the guns, we should be focusing on the child. And so we developed this program called the Anti-Fragility Initiative based upon the concept of the Japanese art form kintsugi, if any of you are familiar with that. The kintsugi artwork, ceramic, is Shogun had this beautiful bowl, he dropped and broke it, and he was devastated. He wanted someone to fix it, and the only one who could fix it in the entire place he'd given up was an artist who filled the broken pieces with gold, and he took the broken pot and repaired it with gold and made it more valuable. And as I thought about the work that we were doing in violence, I realized that hurt people, something I didn't understand until I thought about that. And as a pediatric surgeon who did trauma, I recognized that if I saw these children as people who were hurt and healing, that I could change the way I saw violence and change the perspective that it wasn't moral deficiency, but it was that they were in the process of healing. They were injured and healing. And so, sister, I hope that you can relate to my understanding of this, is that if hurt people, then those of us who are healed can heal those people. So we developed a program that we decided that we were tired of pulling people out of the water downstream. How could we work upstream to the neighborhoods, to the communities, to the homes that these children were coming out of? How could we have impact in the community and not just this? So here we got to this concept I'd been studying for a number of years of human-centered care. How could we bring health and healing to well-being? Not healthcare, but how could we bring that together? And so this is the concept of human-centered care that I talk about or design. It's based on empathy. That's the core. Defining the problems. I took all my moleskins, I read them, I saw my subjective note, and working with a medical student, we designed this program. Sorry, my fingers are happy. We brainstormed, we ideated, we created a prototype, we tested it before we implemented it in the community, we tested it in the community, and this is what we came up with. I'm sorry I'm going through this quickly because I want to stay off time. We called our program the Anti-Fragility Initiative. So think about it. If something's fragile, if I have a goblet, I drop it and it breaks and it shatters, that's fragile. We can't put that back together again. If I have a sword as shown here, that's robust. That can't be bent. But what anti-fragile is, it's different than resilience. I hate the term resilience because we use it all the time, but any one of us here who is injured and paralyzed will never be the way we were before. It's a false narrative. And so we set people up for failure by saying, oh, just bounce back. But what anti-fragile is like DNA. It's broken and put back together again, and it's stronger and more effective. So instead of bouncing back, we like to think that we want to help our children bounce forward. And this is the concept of Nassim Taleb. And there's the kintsugi pottery that you see there. So we invested upstream. This is our program. That's our logo. Stronger in the broken places. Another lesson from my grandmother who loved Hemingway. The world breaks everyone, but afterwards some are stronger in the broken places. The core values of our program: community, equity, prevention, opportunity, and care. And you can see there are the different components. Our specific aims: we wanted to keep the kids from getting re-injured again, help them heal so they weren't retaliating. We wanted to mitigate the stress in their community. We wanted to help them with achievements that were important to them, sports, academics. And we wanted to create a hospital that did not see them as bad, but understood that they were in the process of healing. Our program ran for 12 months, and this ADD is kicking in. I'll show you what we did from an infographic standpoint. We met the kids at the bedside, and we engaged them with our social workers. When they left the hospital, within 48 hours, we were on the phone with them. Within a month, we were in their home. And we aimed to do several things. We wanted to know where they were medically. We wanted to be their medical home. We wanted to understand who they were and who they aspired to be, so a sense of identity and a sense of purpose. And we met them in what we call the teachable moment, when they were at a time that even the toughest of boys was going to be open to us. So this is the governor now of Ohio. I met him when he was the Attorney General. We convinced him, although he was a little reluctant. He's politically far to the right wing, but he is a very devout Catholic, and we were able to appeal to his sense of purpose and spirituality. And ultimately, he liked the idea. We were the signature program, and he ultimately gave us $4.5 million over a period of about 5 years to do these things. I'm going to go through how we developed the program to get to the results. So what we do, in simple terms with our program, our goal is to teach hope. I know it seems corny, but we aim to teach hope, a positive orientation for the future. And we take children who have been injured and move them from hurt to heal, to hope, to whole. And the wholeness is very important to us because I feel that no one heals on their own. We all heal within a sense of community. We aim to build community. We talked about the stuff that we've done. We've seen, that slide's an error. We've seen 700 children, 3,000 families. When a child is sick, a family is sicker. 30% re-injury rate to 12%. The repeat suicide or depression rate is down to 15%. No one works alone. We collaborated with these agencies in Cleveland. We created in the in the emergency room in the hospital, trauma-informed training for our nurses, providers, to help people understand how their interactions with people who are injured may be the second injury. And we trained a number of people. And then we ran a highly popular course in the medical school called, the seminar was called Physician, scientist, healer, and leader, in which we brought a series of people in from around the country to help people understand how to embrace their humanity and how to meet patients where they were. Humanity and humility equals leadership for us. So, as you move forward, as you think about simulation and innovation, I would like you to have courage, collaboration, and compassion to meet people, to meet patients in stressful situations, in places you may not find yourself, with those components to make impact. And finally, I see simulation as not only about improving skills and designing devices, but about cultivating a mindset that we just described. When medicine embraces simulation as a tool for social innovation, we create bold, human-centered solutions that can transform not just communities, but also society. This is a Ugandan boy, but it could be a Southern boy from Lynchburg, Virginia, like me. I love cabbage. And when I see this picture, I don't think there's anyone in the world who's happier than this young man. And I think those of us who are in pediatrics, who are related to pediatric care, want to do that, because if we can do that for him, we can make his mother and father even happier. So thank you for this incredible privilege to spend time with you, to go over, I guess, only by a minute. And I'm sorry I ran through quickly, but it's been such an honor to come to Peoria. I understand now, not by reading in a book or looking on a map, what it really means to be from the heart of the heartland. Or better yet, you guys are the pulse of the heartland. To the people who've hosted me, thank you for your immense hospitality, and I'm open for any questions if people have them. You're welcome. Good. Yes. Yeah.
They were all innocent,
Mm-hmm.
but I obviously wasn't paying attention to what's going on in our community like you have. I really appreciate that. How do you relate the single-family homes versus two-parent homes?
Yeah.
In terms of adding to part of the problem?
So I get asked this question often. And so one of the things that I encourage people to think about, particularly those of us from various ethnicities that I'm not a part of, but even my own ethnicity, kind of the Western European approach is that people have two parents in a home, and there's a family. But there can be aunties and uncles or grandfathers or in a home. So the home is where you have people who are supportive and who love you. And so I'm not so locked into that two-family model. I'm more locked into what is the strength and function of the home, what are the resources. In my own upbringing, I can't even talk about my father without being emotional. I want to be my father. I make more in 2 years than my father made his entire life. My father worked away in Washington, D.C., 3.5 hours away. And so it was just me, my mother and sister, and my father's mother next door. And so I never felt daddy deficient. So I think we have to be careful, but people have what they have. And so the goal is to build community. The flip side, I grew up in a really, really strong, cohesive community. And so I never really felt, and this is a bad four-letter word, but I hope it's okay to see, but I never felt like I wasn't loved. Not just by my family, but by the people in our neighborhood. So again, that's why I say we don't heal unless we build community, both in the home and outside. And it won't always be perfect. And I don't want to sound Pollyannish, but that's our opportunity to build support systems. So what we found that's made our kids, the most successful kids in our cohort have been those who've been able to form therapeutic relationships with our social workers and others there are some big brother men that we connect some of the young boys with, and having that person who can be reliable is important. And I think those of you who are here may have lost parents as children, and you know that you're fine because you had aunts and uncles. So I think we have to be careful that we don't make those stereotypes. But I think that's a great question. I'm asked that a lot. Yes. Mm-hmm.
Noting that in the last 5 years, between them, they were arrested 25 to 26 times.
Mm-hmm.
What is being done preemptively for these kids in communities
Mm-hmm.
to keep them from getting to the point where they're killing someone?
Yeah.
I love this.
Mhm.
Turning, once they're injured and inpatient is, a piece of it.
Yeah. Great question. And nothing really, because no one, I mean, who's paying for preventive care to keep people from getting diabetic or gaining weight? We don't approach prevention. We only approach punitive actions. And the reason we started this program, because we found that the people getting shot had been shot. I mean, the people who were doing the shooting had been shot. And so we found that the greatest risk for someone getting shot was, we cut the re-injury, those people retaliating down to about 2%. There is no one who is helping people help mitigate the anger that they have. And so if you have access to a gun, you may do something that you don't want to have. And so when I met Governor Michael DeWine, Lieutenant Governor, Attorney General, he came to our city to the Boys and Girls Club, and we were talking about this. And I was there with a bunch of adult people, and I had my hand up, and they ignored me. And as he was walking out, I accosted him and said, "Mr. DeWine, I have a program I want to tell you about." And he put his hand up to my face. He said, "I don't have any time for you." And he kept walking. And I don't know what got into me. I kept walking with him. His security people came up and got in, and he got really annoyed and looked at me. He said, "I told you I have no time to talk with you. Is it doctor?" And I said, "Yes." And I just kept talking. 30 minutes later, we were still talking. And he said, "I really have to go now, but can I call you?" And that's what resulted in $4 million. And so we were able to appeal. And I think he got the fact that if we're not doing something upfront for children, they're going to be hardened adults. So, but we can't get funding from a lot of people for this. Yes. 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 Yeah. So my big, hairy, audacious goal, BHAG, is there are a lot of smart people at CASE. We're developing mathematical models because we know things about their mothers. So I want to predict, what we want to predict is the baby that's being born today at McGee Women's Hospital in Cleveland, who has the highest risk to be shot or to be a shooter, and that we can begin the intervention in his family now. And we found that in certain zip codes, some of the kids never get involved in violence. And we found that the biggest factor, other than food insecurity, a lot has to do not with there being not being a father in the home, but what the mother is like. And for those of you who know any animal behavior, and I don't want to offend anyone by this, but this is actually, there's something called their mother licking. The rats that lick their babies more frequently are the babies in animal models that are more secure, who live longer. And so it says something to the effect that maternal parenting is really important. Now in the humans, there may be a father component, but fathers don't take care of their kids. So that what my philosophy is that we need to do upstream things to 10 to 14-year-old girls before they become pregnant, to help them be more secure about who they are, delay their sexual activity, their pregnancy, and that if they do have a child, that we can empower them. And so again, that's another big financial thing that won't get funded, but I think it's so important to work upstream to the mother, not even to the baby or child, but we also would like to do some early intervention programs in children. We find those kids that went to Head Start are less likely to be shot than those who didn't. Other questions? Yes. For older groups? Mm-hmm. Yeah. Mm-hmm. Two different populations and strategies. Yeah. Yeah. Mm-hmm. My advice is to do the adults first. And yeah. Mm-hmm. That's awesome. Mm-hmm. Yeah. Mm-hmm.
Collaborating with the different resources that are in Victoria. One thing I've learned is, they've learned too, is not really a lack of resources in Victoria, there's a lack of communication in Victoria.
Yep. That's mhm. That's awesome. So Cleveland is very much the same way, heavily siloed. They just created a, if you will, czarina to oversees everyone, all the programs. So the thing that I've been most impressed with since I've been here has been this Simulation Innovation Center. And this morning I spent time, and I would say that think out of your boxes or group silos and speak with people here, speak with bioengineers, people here in the center, because even though they don't work directly with that population, they may have ideas, they may have design that can be incorporated. Their intellect, insight may be very helpful. So I would encourage you. I saw some things this morning related to how we can empower children. The boxes that have things. So I would learn as much as you can about what's going on here and hopefully engage people. Yes. Yep. Uh-huh. Yeah. Yeah. Mm. Yeah. Lead with your heart. People don't care how much you know, they only know how much you care. And many children or people who've been injured have been traumatized by people who look like them, people who look like them that they don't know. So there is a tremendous distrust. And in many communities, the people are black and brown, and you don't appear to be either of those. But our most successful social worker is a white male in our group, and he leads with his heart. There's some people who don't feel comfortable with him, but they're teenage girls who feel comfortable, teenage boys. And I think that people understand with time your sincerity. The thing I learned with being a father is don't promise things you can't deliver. Making sure that if you tell a patient you're going to be back at 10 o'clock, that you come back at 10 o'clock. And people, everything is a test. They're testing to see if you're consistent. But just keep doing the work. Because I'm at OSF, I can say this, so I grew up not only in a devoutly spiritual family, but in a devoutly Christian family. And a part of that, and doesn't relate to everyone, is you just got to be sincere to who you are, whatever your purpose is. So yeah, they don't look like you. And I would advise you to not take too much solace in the hip hop song, They Ain't Like Us. And because sometimes even if you ain't like someone external, there's a connection. Yes. Mm-hmm.
I think I voted down by our.
Yes, and the American College of Surgeons too.
And if you shot by an AR-15, a child shot, they're not going to survive for the most part. Low velocity weapon shootings do survive, but AR-15s, they don't. In your thoughts, and when you're talking to politicians, when you're going around the country lecturing, what's going to break the logjam in this country to limit access to AR-15s? Because a lot of these things you're talking about, it won't help. We don't get rid of the AR-15.
So as you know, I speak a lot. And as you know, I speak to a lot of politicians. I speak to groups that, I'm sorry, I missed your name. What's your name? Deus? Yes, Dayton. I speak to groups that don't look like me. And so I'm very careful if I respond to this question and it's ever quoted. So I believe in the rights of the Second Amendment. And so I kind of leave it there. And I support the president, the Senate, Congress on the decisions that they make. If they change, and the Supreme Court, if they change their opinions so that we can't have those weapons, I would support that as well. And so that's where I will leave it in a public space. But the strange thing in Chicago, when I was in Cleveland, we saw lots of gunshot wounds. No, but it's just one bullet, maybe two. The average number of bullet wounds in Chicago is 6. And I just hope our leaders, can just pause for a second. But I mean, if you step back and look at this, a major political voice was killed recently by an automatic weapon, and the dialogue doesn't change. So, yeah, right. But I think, though, I mean, another lesson from my father: those things you can't control, but you can control you, and you can continue to be an advocate and a voice, and you can connect with people to find those kindred spirits who can help you achieve those things that have impact on the human condition. Yeah. Yes. Oh. Yeah. Mm-hmm. Yep. So that I will speak on. I recognize it's an executive order, and I grew up in an environment where we were to respect authority, even if we disagreed with that authority. So I'm upset by those changes because I don't think we fully understand what DEI means in this country. And I think there's a vision that it often means preferential treatment for certain people at the expense of other people. But there are things that individuals contribute that are uniquely able to contribute. I was just speaking last night at dinner. Before I went to college, so my mother was a seamstress in a sock factory, never graduated, finished the 10th grade. My father was a high school graduate. I went to an enrichment program for underprivileged minority kids going to the Ivy Leagues. And in my cohort of 100 people, 1/3 Asian, 1/3 Hispanic, 1/3 African American, there are probably 5 of the most accomplished physicians in the United States, and we were all let in through the wide gates of affirmative action. I think it's often hard to evaluate what talent is. And so I think we need to think as voters and as a country, what do we want our country to look like and feel like? And we need to go deeper than what the political pundits on both sides tell us, or the news media on both sides, and look at how we want to build our country. And so I support the DEI initiatives to some degree. I'm not a person that likes the word DEI, and I've always said, different talk, that it is discriminatory at times for some people. And so we have to look deeply into what we want programs to look like that allow everyone a sense of justice. I like the word justice over equity. Justice gives everyone access to the American dream. Did I answer any of your questions? Yeah. You can say no. Yeah. Anyone else? Oh, great. Rick, thank you. And maybe we'll see you back in Solon. All right.